I'm here today with Dr. Joseph Biederman. He's the Chief of the Clinical and Research Programs in Pediatric Psychopharmacology and Adult ADHD, as well as the Director for the Bressler Center for Autism Spectrum Disorders at the Massachusetts General Hospital. He's also a Professor of Psychiatry at Harvard Medical School. Dr. Biederman is going to be speaking at the 7th Annual Meeting of APSARD, the American Professional Society of ADHD and Related Disorders. Their meeting is January 15th to 17th, 2016 at the Mandarin Oriental Hotel in Washington, D.C. Dr. Biederman's topic is going to be ADHD and the risk for bipolar disorder, integrating findings from research in children. So what do we know now that you're going to be sharing about research in children for bipolar disorder, Dr. Biederman?
I think I would say over the last 20 years, there has been an increasing awareness in pediatric psychiatry that a sizable number of children, probably around 1%, have bipolar illness. That is also supported by the fact that roughly 70% of adults with bipolar illness start their illness in childhood and adolescence. A full 1/3 of adults with bipolar illness started their illness before the age of 12. So if you consider 2% or plus of adults with bipolar illness, if 70% started in childhood or adolescence, we face a real problem that somewhere about 1% of children may be affected. The problem in the field of ADHD and bipolar illness is that about 80% of children with bipolar illness also have ADHD. It's not in reverse. The rate of bipolar illness in children with ADHD is around 20%. So the overlap is quite substantial, but particularly very, very high in children with bipolar illness. The reason that this is important is because bipolar illness and ADHD may share some symptoms, but they require very different treatments. And the treatments that we use for ADHD can make worse the symptoms of bipolarity, particularly if we use medicines like stimulants or medicines like antidepressants if the diagnostician confuses unipolar depression with bipolar depression. So these things are very consequential to the well-being of the child. Children with bipolar illness frequently are violent, aggressive, and can be out of control. Very often they're so out of control that they need to be hospitalized and they become dangerous to self or others. So the differential diagnosis of ADHD from bipolar illness has enormous clinical and therapeutic consequences.
Are there shared symptoms between ADHD and bipolar disorder? How difficult is it for the clinician to distinguish between the two?
Yes, the answer is that there are symptoms in common, but they're different. So hyperactivity and agitation are not exactly the same. Hyperactive children move a lot, but they are not in an agitated state. Children with ADHD tend to talk a lot, but children with bipolar illness talk so rapidly that sometimes they cannot be understandable. But the major differentiation is in the abnormal mood. There is nothing in ADHD, in the defining features of ADHD, that speak to abnormal mood. These children have very, very dysregulated mood. They frequently have the combination of aggression, manic symptoms, and depression all at the same time. It's a very complicated clinical picture that is usually known as mixed mania. Children with mania, more often than not, tend to be irritable, violent, and aggressive, not euphoric. So the children present usually at a very young age, usually with symptoms of discontrol and violence. Very often the symptoms are present at home for a long time before they spread to the school, because when the symptoms emerge in the school, the child becomes unmanageable and usually is brought to the emergency room. Despite the fact that some symptoms overlap, there are very, very important differentiating features between ADHD. Remember I said before that 80% of children with bipolar illness also have ADHD.
Yes.
And the ADHD that they have can be very severe, but they also have mood dysregulation, irritability, and sometimes violent behaviors.
This is going to be a very important discussion, and this is going to be held at the 7th Annual Meeting of APSARD, the American Professional Society of ADHD and Related Disorders, this coming January in Washington, D.C. Hope you'll join us, because as a clinician, it's going to be very important to be able to understand these distinctions. Thanks so much for being with us today, Dr. Biederman.
My pleasure.